Hi, welcome to another conversation with Swallow the Pill. Once again, my name is Zena, and I am your friendly nurse educator. I have been a nurse for the last 14 years, so the goal of this channel is just to be able to share some of the nursing knowledge that I have acquired over the last few years and to kind of help make things easier for patients to understand. Oftentimes, I notice just in the procedural area that I work in, when we're bringing patients back, they don't necessarily completely understand what's happening or the procedure that they're having, and they have questions. And at that point, all of the questions should be answered. So the goal of my channel and the goal of Swallow the Pill in general is just to be a voice to help you have knowledge and education so that you can better advocate for themselves. Thank you for watching. If this helps you in any way, please like and subscribe. So the topic for today is conversations you should be having concerning your health. Who should you be having these conversations with is up to you. It's up to whoever you deem as important in your life, whoever you consider as eligible to speak for you if you was to ever become unable to speak for yourself, or just friends in general, just to discuss with anybody that you deem important in your life. Oftentimes working in the hospital, you see different things, and I personally have a background in ICU. So oftentimes the patients that I would see, it would be an emergency for them and their family. It's not just about the patient, but their family as well. And so oftentimes it would be difficult for patients' families to make decisions for them because they hadn't discussed it. They don't know. And so they're just trying to guess what the best case scenario or the best decision that they should make on their behalf. And sometimes it works out great, sometimes it doesn't. So the goal of today is I'm going to give you some of the common topics that arises, especially in an emergency situation, that you should take and consider, talk about with your family, talk about with your friends, talk about with people that's important to you. That way, if you are ever in this situation, you understand what's available to you, you understand what the doctors are presenting to you, and you can make the decision based off of an educated guess versus an uneducated guess, okay? Before we get started, I do want to give a disclaimer. Not all hospitals are created equal. Some hospitals have more resources than others. Some hospitals are smaller, so they don't have as much resources. So when you are choosing where you are receiving your health care from, be mindful of where you are. I grew up in a very small town, and the nearest hospital there was 20 minutes away, but it was a very, very small community hospital that did not have many options. So if I went there and I was actively coding, or I had absolutely, my heart had stopped, that hospital would not be able to offer me and my family much resources. So I say that to say this. A lot of hospitals that do have a lot of the resources that I'm going to talk about, they are level 1 trauma centers, level 1 teaching facilities. They are the bigger hospitals. So I give this disclaimer before I go into the topic that I'm going to talk about. Not all hospitals are created equal. You're not going to get all of the same services at every hospital that you go to. So when you are deciding on where you are receiving care from, choose wisely. If you are near a level 1 trauma facility or a level 1 medical education facility, go there, because I guarantee you they will have a lot more resources than your small community hospital. And that's not to say small community hospitals don't have much to offer, but if your heart was to stop or you was to stop breathing, you want to be able to say you were in a position to where everything that was able to be done for you was done. And you want to be in a facility that can provide that. Okay, so the first topic that you should talk about, your code status. That is the number one thing that they are going to address when you enter a hospital. Unless you already have an advance directive, meaning you already have something in writing, something filed somewhere, something like a living will or a trust that says that you are something other than a full code, then when you enter a hospital, you are automatically a full code. Unless you tell them otherwise, unless they question you and you say, yep, this is what I want, this is what I don't want, you are automatically a full code. What does being a full code mean? If you are considered a full code, that means if your heart was to stop, if you was to stop breathing, or your body was compromised in any way, that hospital, that facility, they are going to do everything in their power to restore you back to your normal self. That means you can be intubated. They're going to sedate you. They're going to start pressors. They're going to start drips on you that can help to support your heart, that can support a healthy blood pressure, that can help support a healthy heart rate. They're going to put a tube down your mouth to help breathe for you. They are going to do everything possible to restore you back to your full health. So if and when you enter a hospital, you are automatically a full code unless you tell them, I don't want to be a full code. And to share some of my personal experiences, just me in general, I am almost 39 years old. I am not a full code. And I am not a full code because of my personal decision. I have already discussed this with I have a healthcare power of attorney that is not my family member. Because I know that if something happened to me, I have specific wishes based off of my experience of working in a hospital, based off of my experience of working in an ICU. And I know if my family, my mom, because I'm not married, my mom and my sisters had to make decisions for me, I know please do everything you can for her. No, ma'am, I don't want that. And that's just where I am in my life right now. That may change if I was to ever have kids or was to ever get married. But currently right now, I am not a full code, and my healthcare power of attorney is not a family member, because oftentimes family members, they do react off of emotions, and it becomes very difficult for families to let go, especially if it's an unexpected emergency. So I chose someone that I know is going to follow my wishes, and I have a living will, and I have paperwork already done that says what I want. So that's what my decision is. So I urge you to discuss this with your family. Do you want to be a full code? Do you want them to do everything in their power for you? Yes or no? That's something that you should discuss. The next option would be a DNR, which means do not resuscitate. Do not start chest compressions. Do not put a tube down their throat. Do not do anything. Let natural causes take its course. So DNR, do not resuscitate. It is not to be confused for a do not treat, which oftentimes does get convoluted in the hospital setting, especially if you have a DNR that's in the ICU that is on blood pressure medicine supporting their heart and their heart rate. Sometimes there's some convolution in that. Sometimes people don't understand, oh, this patient is a DNR, why are we doing this? Well, a DNR does not mean to do not treat. A DNR just means that if your heart was to stop, or if your body was to stop breathing naturally, then you don't want anything done. You want a natural course to take its place. And that's perfectly fine if that's your choice. But understand, when you enter a hospital, you either have the option of full code, which means please by all means do everything. Please come in here, jump on my chest, do chest compressions. I want a tube down my throat. I want everything. Please throw the whole trash can at me and please bring me back to life. That's what that means. Or a DNR, do not resuscitate. Let me die. Let me die peacefully. I don't want any chest compressions. I don't want any drugs. I don't want any tubes. I don't want anything additional. That is what that means. So that is something that you should discuss with your family and to determine what is your wishes currently at this moment. That way, if you was to ever be in that situation and you can't make that decision for yourself, your family already knows what your wishes are. So I've said intubation numerous times already. And what that means is, so if you are a full code and you were to stop breathing, or you were in a position to where your body cannot exchange oxygen and carbon dioxide safely, which means something is not functioning, balancing right, then they would intubate you. And what does that mean? That is when you will see them take a clear tube and they're going to put it down your mouth and they're going to attach it to a machine and have that machine breathe for you. Now, that machine can be set to different settings. There's the settings of where it's taking over complete support of your lungs, it's doing all the work. And then there's settings on that machine that where allows the machine to do part of the work and have your body do some of the work as well. So they can do a number of things with that machine. But the important part in that is if they're intubating you, that means that you are consenting to a tube being put down your throat and you're having a machine breathe for you and do the work of your lungs. That's something that some people want, and that's also something that some people don't want. But one of the things I do want to make you guys aware of that I don't think people know and realize this. So when you are in a critical care setting, ICU, intensive care, and you are intubated, there is a clock set to that intubation. And what I mean by that is you can only be intubated for so long before those doctors have to then have a different discussion to figure out a more long-term plan. The time clock for intubation is 2 weeks. Now, I say that loosely now. Some nurses might say, oh, we do it differently at my hospital. That's perfectly fine if you do it differently at your hospital. But the hospitals that I've worked at, a lot of times the doctors, coming up to that 2-week window, they start saying, should we trach this patient? Do this patient want a tracheostomy? And that is because if they leave the tube down your throat, all of this, the tissues and stuff within here starts getting irritated and starts breaking down. So then you can have internal wounds that they cannot see that they would then have to treat. So a more long-term breathing plan for you would be to put in a tracheostomy. A tube that goes directly into your trachea is just, instead of it going through your mouth, they're going to make an incision right here at your trachea and insert a tube there. That can be in more long-term than the tube through your mouth. That can also still be attached to a ventilator, which is the machine that is breathing on your behalf and doing the work of your lungs. It is a more long-term solution to resolving respiratory failure, respiratory issues, respiratory compromise. Now, there are also risks that come with having a tracheostomy. There is also some upsides to having a tracheostomy, and there's also some other factors that people should consider before deciding that that is something that they want. Those other factors include, if you have a tracheostomy in place, it does compromise your ability to eat by mouth. If you have a tracheostomy in place and an intubation tube in place, you are not able to physically eat with your mouth. So that means the hospital will then need to either find you another source of nutrition. That other source of nutrition can be a feeding tube, which can go through your nose. It can also go side by side with the intubation tube, or it can be incision that they make within your abdomen directly, and they do a nutrition source. It could be, we call it tube feed, or some other source. They also have TPN and PPN that can go through a PICC line. But if you have a tracheostomy, you are not able to physically eat food initially. Now, once you've had that tracheostomy for an extended amount of time, you can graduate to a point of where they can allow you to eat. But that is not something that you get up front. That is not something that is immediate. That is something that is far, far, far down the line. Another issue that comes with having tracheostomies, you do lose your ability to have a voice. You can try to talk, but there will be nothing that come out. Now, if you have a tracheostomy and it is directly connected to your ventilator, you will not be able to talk. Now, there are moments or situations that will arise that they can wean you off of the ventilator and allow you to not have anything attached to the tracheostomy. And you can have a Passamere valve, which will allow you the ability to have your voice, but you will have to have that on your trach the entire time in order to use your voice. So that is something that people should consider. If you have a tracheostomy, you're not able to physically eat directly initially. You're not able to physically have a voice. And sometimes tracheostomies can be a little uncomfortable because initially, especially for the first 7 days, they do have sutures in place. And sometimes if you cough, because a lot of times a lot of coughing is directly attached to having a tracheostomy. I think sometimes when it kind of moves back and forth, it does irritate some things in there. And so people have a more frequent cough and it pulls. So sometimes it can be very uncomfortable for the patient. But those are things that people should consider when you're considering a tracheostomy. And that is something that the doctors will discuss. You know, they'll tell you we're coming up to the 2-week mark. So we need to make different plans. And tracheostomy is a surgery procedure. I have seen hospitals do them at the bedside, although I personally would not advocate for that. Please take this patient to the OR and do that in a sterile environment. But that is a conversation for another day. But I'm just giving you this information so you have this information. So, full code, DNR, then we go into, do you want to be intubated? Intubated means you have a tube down your throat, which if you can't be weaned from that within 2 weeks, that means that can turn into a tracheostomy, which still turns into you being connected to a ventilator that they can later wean. And another fact about a tracheostomy, it can be reversed. So it's not something that you have to necessarily live with for the rest of your life. It can be reversed. But in order for them to reverse that, you do have to get back to normal breathing on your own. The respiratory failure have to be healed, and you have to be back to a place of where you can adequately have oxygen exchange safely and balanced in order for them to be able to reverse that. Okay, so another decision that you should think about, if your kidneys was to stop working, or if you were to get into a situation to where your creatinine kept climbing and climbing and climbing, and the doctors came to you and said, your creatinine is in an unsafe range, we need to do something to treat this, would you want dialysis? What is dialysis? There's multiple forms of dialysis, but what dialysis does in a general sense is it basically removes the waste from your body, right? Dialysis there's a number of ways you can do it. There's a machine that will attach to you, and you'll see your blood come out. It go through a filter. Sometimes we can give stuff to you. Sometimes we can take stuff away from you, and we'll give it back to you. So basically, we're pulling blood out of your body, putting it through a filter, cleaning it, filtering it, doing what your kidneys should be doing, and giving it back to you. Now, they can also give you volume by doing this. They can also give you blood by doing this. There's a number of things they can do with dialysis. There's hemodialysis, which is a form of dialysis. And then there is CRT, continuous renal replacement therapy. Now, the difference between the two, which is what's important here. Hemodialysis, they put you on, they can take off a large amount of volume at one time, 1 liter, 2 liters of volume, give you your blood back, take you off, you're done. You sit for 4 hours, 3 hours. Sometimes you have to do this 3 times a week, sometimes a little bit more than that, but oftentimes it's 3 times a week. Sometimes you see people Monday, Wednesday, Friday, or they might be on a Tuesday, Thursday, Saturday schedule, but they can take off a large amount of volume at one time. Now, the thing about that is Can your body handle that amount of volume coming off in such a short amount of time? Yes or no? Sometimes patients can, sometimes they can't, but it's great to see it in the hospital setting, because if they start having issues with their blood pressure, it can be treated, especially if they are in an ICU setting. Now, the other form of dialysis, the CRRT, or the continuous renal replacement therapy, I think that's what it stands for. I need to look that up to be sure, but CRRT is what I know it as, is basically more so used in an ICU setting. It's where they can remove smaller amounts of fluid over a longer time frame. Nurses are directly there managing it, and so they're able to have more eyesight on it. And what I mean by smaller amounts of fluid, so instead of removing 2 liters over 4 hours, I'm only removing 50 mLs an hour. And I'm watching your fluid balance over a 24-hour time frame. And I'm able to adjust based off of the patient's condition. Because like I said, with hemodialysis, sometimes patients can't tolerate the large amount of volume coming off, so their blood pressure will drop. Well, if you have CRT and you're removing smaller amounts of volume, and you see that, oh, when I've taken off 100 mLs, my blood pressure became a little soft. So now you can communicate with the ICU doctor, and you can maybe give a blood pressure medication to treat that. Or you cannot pull the volume. You can just do the filtering process. So it can be a little bit safer to manage with the patient while they're in the ICU. So consider that. That is a question you should answer yourself. If your kidneys stop working, do you want hemodialysis or any form of dialysis? You will have an attachment. There's different attachments, and that is a conversation for a different day. But it is an attachment that they connect the dialysis machine to. Filter your blood. They can either take away or leave it as it is, do the filtering process, and then take you off and treat you that way. And that way they can monitor your kidney status and see how well you're tolerating that and go from there. Okay, so another thing to consider when you are in the hospital or when you're talking about your health, the decisions that you're making for your health. If your heart was to stop, if you was to stop breathing naturally on your own, do you want to be on ECMO? What is ECMO? Now, there's 2 different types of forms of ECMO, but it's still the same machine, but 2 different types. There's either VV ECMO or VA ECMO. VV ECMO only does the work of the lungs. So if you had any sort of respiratory failure or your lungs was compromised, VV ECMO is the way to go. Or if you had a situation where your heart stopped and they did chest compressions on you, VA ECMO is the way to go. VA ECMO takes over the function of your heart and your lungs. VV ECMO takes over the function of your lungs. ECMO itself is not a cure. It does not cure the issue at hand. If they was to stop that machine as soon as they turned it on, the issue would still be there. But ECMO is a bridge. It is a bridge to get you to better. Either it's the bridge that will allow your heart and lungs to take a break to heal without having to do any work, or it's the bridge that will get you to an LVAD that can support your heart in a more long-term fashion, or it's the bridge to get you to transplant. Either you need a heart and lung transplant and you're waiting, you're on the list, and things are progressively getting worse and things are just not looking good, and you have coded and you are crashing, ECMO can be the way to go. Now, I give a very bland description of ECMO for a reason, because it can be very hard to understand. And ECMO is not in a lot of hospitals. Now, I started in a hospital in South Carolina and I never saw ECMO. I work in California now, and ECMO is a very common thing out here. I saw patients die in South Carolina from things patients walk out of the hospital here after being on ECMO from. So that is something that you should think about. ECMO. ECMO is 2 large cannulas that go into your body. The blood comes out of your body, goes through another filter, and it goes back. I'll put a picture so you can see what it looks like, so you can decide if this is something that you will want for your health if you were ever in a situation to where you needed to make this decision. Okay, so I know I've given you a lot of information to think about. I am sorry if I'm long-winded. Just to wrap this video up and to recap. So what we talked about was full code versus DNR. Sometimes patient can be a DNI, which means they just don't want to be intubated. Sometimes people also give us, I don't want chest compressions, but I want medications. Just to give you some understanding behind that, if your heart has stopped, blood is not moving. So if you are saying, I just want medications, I don't want chest compressions, the medicines ain't going nowhere. It's just going to be sitting there. Because if your heart ain't moving or somebody is not manually doing chest compressions to move your heart, which is what compressions are, then the blood is not flowing. So if you are one of those people that is like, oh, I just want medicines, I don't want the compressions. You need the compressions in order for the medicine to move. So just understand when you're making these decisions, you have to be wise about some of those decisions. And I'm not saying that that's not wise, but sometimes people don't understand. Like if your heart is not moving, there's no way we can circulate those medicines through your body, which your body needs those medicines, especially if your heart has stopped. So full code, DNR, DNI. Do you want to be intubated? Do you want a tracheostomy? Do you want dialysis? Hemodialysis, CRT dialysis. Some hospitals might not have CRT dialysis because, once again, the hospital that I started at in South Carolina did not have CRT. They might have it now. I hope they have it now. It's been quite a few years since I've been there. But some hospitals might not have it. They might only have hemodialysis. But if your kidneys wasn't working, do you want dialysis? And then last but not least, if your heart and lungs was to stop, do you want ECMO? Do you want to be ECMO'd? Do you want the large cannulas that could take some time? You might have to sit on ECMO for a couple of weeks before they can take you off. It also comes with a lot of risk, which I did not go over on purpose. I will do another video talking about ECMO and some of my experiences with ECMO. So I've given you all of these things to consider when talking about your health. So have the important conversations with your family. Have the important conversations with the people that you love the most. That way, if something ever happened to you, people know what your wishes are. Make your wishes known while you are in your right mind and you're not compromised before you ever need to. That way, if something happened to you, it is your decision, not theirs. Thank you for watching this video. I hope it helps. Swallow the pill.